September board of the George Eliot. If I could ask everyone to put their microphones on mute, that would be great because we just get a little bit of feedback. Nice to see everyone. Hope colleagues have been able to take a bit of a break. So we've got quite a full agenda today, but one of the things we do and enjoy doing is the iExcel Awards. So we have apologies from our Managing Director, David Elchingham, but Catherine, our Medical Director, is going to lead us to the celebration of the iExcel Awards. So over to you, Catherine.
Thanks very much, Russell. Well, it's a great opportunity to be able to celebrate one ward and one person who have really made a significant contribution to George Eliot, and these are for the first quarter of the year. So is Andre here, Rebecca?
I was just looking through participants and I can't see his name, so unfortunately I don't think he's been able to make it.
All right, well, I'll go to Mary Garth because I can see Sharon's name. And Sharon, have you got the people from Mary Garth with you?
Good afternoon, everybody. No, sorry, I haven't. Karen was joining, but I'm not too sure she's managed to do so.
All right, well, we'll celebrate them.
A select crew.
Here, and if people join us, that'd be wonderful. So I'll start with Mary Garth. Mary Garth, earlier in the year, very sadly lost two much valued and much loved colleagues, Vic and Roland. And unfortunately, both of those colleagues died on the same day. It really impacted on the ward, and you know, they've had a very hard time. But this nomination, here comes Andy, this nomination is it really in respect to the way that they've coped as a team. What the nomination says is losing two work colleagues has challenged the team. It has demonstrated on many levels that at the centre of our working relationship is our respect for each other. Grieving for our colleagues can feel unnatural, but with the strong support from the team and acknowledging the impact of these deaths, we have become a closer and stronger team. A safe environment was created that everybody had access to be able to talk, cry, or just laugh at the funny times. No judgment was made. Many people throughout the trust felt the impact of these two wonderful people who provided wonderful care to patients. Whilst the team was grieving, our patients still received the care that they deserved. And Sharon, who is the matron for that ward, is on the call today, and she's been telling me about the resilience, the supportive nature of the ward, the fact that they cover, you know, they've got very few vacancies, cover for each other. So well done to Mary Garth ward, excellent care for patients and for each other.
Well done, team. Thank you.
So the next one is Andre, and I think he has joined us as well. I think, Andre, you've moved on to pastures new now, but this just fills my heart with joy to be able to see these nominations in front of us. So I'd like to read these nominations. You've got two here, but you can see why Andre was an iExcel winner. So the first one says, I'd like to nominate Dr. Luckiewicz for the Excel Award. I've worked with him in my first ever job, surgery, as well as alongside him in A&E during my medical job. Surgery was my first job after graduating, and Dr. Luckiewicz has always gone the extra mile with his support and guidance during this challenging time. I felt inspired by his enthusiasm for medicine, extremely polite and empathetic bedside manner, and his reflection-inviting teaching style. In result, I was able to reflect on my clinical practice and career choices. Dr. Luckiewicz motivated me to get involved in research, quality improvement projects, and to work on my portfolio. I also learnt more about good bedside manner and respect for patient dignity from him than I could have had from most people. I especially appreciate his patience and support during my first weeks in clinical medicine, during my busy surgical rotation. In short, I feel that his support, great communication skills, empathy, teaching, and enthusiasm have proved worthy of recognition. So, I mean, what a testament there. That is brilliant. And there's a second one. Don't stop now, because there's a second one. Despite ED being busy in recent months and despite being challenged at times himself, he always manages to say a kind word to other colleagues. He is very polite, empathetic, and goes the extra mile for all of his patients. This makes Dr. Andy a pleasure to work with. So, Andre, well done for those comments. Well-deserved winner. And I hope you manage to keep that passion and enthusiasm, because you can see in these nominations the impact that you're not only having on patients, but the impact you're having on other colleagues, and the inspirational role model that you are makes you a worthy winner of this award. So well done to both Mary Garth and to Andre.
Oh no, really fantastic, guys. Thank you so much on behalf of the whole board for the phenomenal work you do. And as Catherine said at the end, it's your leadership by example. And there was a reference to being kind under periods of stress, which is an incredibly important aspect of leadership. So really well done. Thank you all for your hard work. You're very welcome to stay for the rest of the board. But equally we'll understand if you want to go and do other stuff. But in the meantime, thank you for being our Q1 iExcel award winners. Take care. Okay, team, well, welcome members of the public who have joined us as well. As I said, we do have some apologies today. David is on holiday. Hack has had to send his apologies. So Michael, thank you for deputising. Stephen is on holiday as well. So Philip, thanks Phil for standing in. And unfortunately, Gert is unwell today, so it's nice to see Sarah again. But apart from that, we're all here. So any new declarations of interest, please raise a digital hand if there are. Okie dokie. So the last set of minutes, was everyone happy with the last set of minutes from the August board? Please raise a digital hand if you had any amends. Okay, I can't see any amends, so I'll duly sign them. But on page 20, we have the action list arising. And the first was that Jenny would ensure future reports focus on place, including the heading better outcomes, better value, so as not to lose sight of that primary aim. And it's quite interesting in the documentation that's come out today. The focus on better outcomes and better value is part of the underlying narrative, which is interesting. So thank you for that, Jenny. Then Stephen, to ensure the winter plans sets out a holistic overview of the trust plan to tackle winter pressures, and that will come back to the next board. So I'm sure you'll be involved in that, Phil, but thank you. And it's worthwhile saying, particularly at the moment to members of the public, that the challenges on our social care colleagues are increasing, and the importance of working as an integrated care system and collaborating with one another is becoming more and more important. Then we had something again for next month, which is the work being done with UHCW to address delayed in-share service referrals. Come back to that next month. And then an update from Sue, our Freedom to Speak Up Guardian, to ensure the nursing and midwifery categories were split. We'll come back to that later, so look forward to that. And I think that was all the matters arising. If there were any other matters arising, please raise a digital hand. Okay, I can't see any digital hands, so I'll take that as complete. So Glenn, we're over to you for your Chief Executive's report, please.
Thank you, Chairman. I probably should start by apologising for the size of the report, because there's quite a lot of guidance has landed over the last few weeks, and what I've done within the report is precede some of that. We spent some time in workshop this morning looking through where we were with the ICS guidance and where we were with provider collaborative. So I won't go through it all. You'll be pleased to hear. The first item, though, in the report talks about some of the current pressures, and we'll obviously look at that a little bit more detail later when we look at the performance report. But kind of unprecedented levels of urgent care demand, recovering elective activity and cancer activity, and all of that alongside workforce challenges. Obviously, we're towards the end of the summer break now, so some high leave periods, as well as staff isolating, and all the pressures of all the activity that we're doing. So it's been tough. And one of the things that I flag in here is a concern around flow and discharge, particularly into the domiciliary and care home sector. Those sectors have been struggling with staff for a little while now, but I think when you look at where the economy is, there are other sectors where jobs are more rewarding, both financially and in terms of being easier than some of the particularly domiciliary and care home work that we're referring to here. And you add to that the concern that we have around the double vaccination law, that means that for any individuals who've not had their second vaccine by the 11th of November, they will be dismissed from working in care homes. That's a worry. Currently, there are a significant number of staff in that sector who have not been vaccinated. And bearing in mind it's 8 weeks between first and second dose, we're approaching the point very soon where if they haven't had their first dose, they face that issue. So this will be a challenging winter, and as you saw in the previous item, we will be bringing back a winter plan before the board in the October meeting. So really quite encouraging that there is reform of social care. Well, obviously next time we'll look at that one in more detail, because as you said, Chairman, it's been announced today. There's a Build Back Better report that's been produced by the Department of Health, and additional funding pledges, and the intention to integrate health and care in a way that we haven't seen before. And a lot of that links into the integrated care guidance, which I say I won't go through. Provider Collaborative, just to point the fact that the foundation group that we're part of features in that guidance. We looked on that this morning and could see that we were helping to get ahead of the curve in the way that those things are now being implemented across the NHS, but we've been doing it here for a little bit longer. Won't go through it other than the directorate update for medicine. A lot going on there, some great innovations, including the capsule endoscopy service, the work of the diabetes team in National Research Project, the respiratory and physiology team, new lead chaplain, which is really important, and then also the work of the R&D team, who've really had to work differently during COVID. And our good friends in Coventry Telegraph, I knew they would take that photograph of the dogs and put it onto their into the Telegraph this week. They did. So the COVID dogs, very exciting development. And obviously, we've also seen the use of dogs in detecting cancer in the NHS as well. So really interesting innovation. But as ever, the George Eliot R&D team really getting involved and punching above their weight in terms of some of the research projects that we're involved in. So I'm happy to take any questions, Chairman.
That's great. Thanks, Glenn. And I just want to add my welcome to Janelle as our new chaplain. And I think Glenn and I have been working together now for almost 6 years, and I can't recall a board report where he's ever had a picture of a dog or refer to a dog. So it's great to see your board reports developing in a canine way. Questions or perspectives to Glenn on the enormous amount of things that are ongoing. Julie?
Just a quick one, Glenn. We've talked a lot about the system today. We've talked a lot about the guidance. It occurred to me during our break, are we expecting any guidance actually to trusts?
So every time new guidance is published, they indicate further guidance will follow. There actually, and I've seen a draft of it, there is some guidance to foundation trusts actually, because particularly to governors, but that hasn't been published yet. I think the main guidance to trusts was about provider collaboratives, and obviously we refer to that in this document here. But I think we just have to wait and see, Julie, because I do expect more to follow, and I think particularly some of the announcements that have been made today around elective recovery, again, we'll want to look at the detail of how that's been managed. And I think that actually will provide a great opportunity for George Eliot to demonstrate how we've improved capacity and throughput. So as it lands, I'll bring it to board and try and see it as best I can.
No, thanks, Glenn. Thanks, Julie. I think one of the encouraging things, though, is our work in the foundation group on that as a provider collaborative model identifying and sharing best practice at pace really is at the leading forefront of some of the recommendations. Simone?
Thanks, Chair. Glenn, it seems to me that we've got the perfect storm brewing in the domiciliary and care home sector. Can we be assured as a board that all the routes are being followed to escalate this to the appropriate people who can do something about it?
Yeah, they are. I mean, it's obviously something on our own risk register, but something that we picked up as a system. I had a meeting of the National Elective Recovery Board last week, where a number of us raised this as our current biggest concern, and the response that we received to that is that as part of this year's winter planning cycle, there's an intention to have a much more joined up health and social care winter plan. Obviously, we'll talk about ours next time, but I think we discussed at workshop we ought to be bringing more of our system partners into that conversation, primary care and social care colleagues, because we will need to work really carefully together to ensure that we manage. We're not going to solve a lot of those workforce crises overnight, but we need to be working on the strategy as well as trying to manage the day-to-day challenges that we're going to face.
Thank you. Thanks.
Point well made, Simone, and I do think we need to, and it's one of the things I'm proud of our focus on place, is working with colleagues at local authority levels and in primary care about raising these issues. And it is, you know, working in the NHS, working in a care home, working in domiciliary care, working in the voluntary sector, all of those sectors which are around providing care. It won't be the highest paid job you can do, but in terms of job satisfaction and having an impact on other people's lives, it is a wonderful thing to choose to do on a daily basis. So I really would encourage youngsters who are looking at different career opportunities to seriously look at it as something which is life affirming and life fulfilling. Any other questions? Otherwise, we'll move on. So thanks, Glenn. Clearly a big agenda which you and colleagues are having to handle. So our thanks as a board to you. We therefore move on to the Estates Quarter 1 report. Kirsty, welcome. Nice to see you. Obviously, this is for receiving and noting. But Kirsty, anything you particularly like to pull out?
Yeah, just this is the first year that we've ever had to formally submit the premises assurance model. In previous years, we've undertaken it voluntarily, but it's now a mandatory requirement that this gets submitted to NHSEI. So the team have undertaken an assessment, which is detailed out in the report. And it's just really, if anybody's read the report, if they have any questions about that particular item on there.
Okay, that's great. Thank you, Kirsty. Any questions or perspectives? I know Julie's got some background noise challenges. Rebecca?
Thanks, Chair. Hi, Kirsty. Quick question. And first of all, just to say it's really positive to see the progress that we're making in regards to our estate work in challenging circumstances. Question really is what arrangements have been made to provide some external assurance on this report, given that this is a self-assessment?
So all of the results get submitted to NHSEI, and I believe CQC have oversight of this. So next time they come in, they'll be validating it.
Thank you.
One of the things we've been very clear about, we've only scored these questions if we're able to evidence that we're actually doing what we've said. So it's a very honest assessment from our part.
Okay, and Kirsty, just in terms of the work with the League of Friends on the canteen.
Yes.
Just update us on that.
Yeah, it was going really well, and then the contractor unfortunately developed COVID and it slowed us down again, but the contractor's now back on board. He was out the other day measuring up, so hopefully work will commence there soon. We've got some heads of terms that we've agreed on, so things are looking really good. Okay. Very exciting.
Okay, thank you, Kirsty. Any other comments from colleagues? Glynis?
Thank you, Chair. It was a really helpful report, Kirsty. Thank you. I just got one query, and I'm certain I probably know the answer, but I just want to check with you. In terms of the maternity theatre refurbishment, which has been delayed again, are there any risks associated with that?
The theatre's just been validated and it passed, and we are maintaining it regularly. So yes, there's no risk at all.
Thank you.
Okay.
Thank you, Glynis. And then with the risk of an alarm going off in the background, Julie?
It stopped just in time. Hi, Kirsty. It was just around the maternity tender that we're going out again. Such a disparity this first time. What have we learned that we're doing differently when we go out to tender this time?
So we're literally reviewing the spec with the cost consultant and the contract administrator to see why the companies would get such a difference. I mean, 1.2 million to 588,000 was a significant gap. So we're reviewing all of the paperwork that's going out to make sure that there are no anomalies in there.
No, thanks, Kirsty. Kirsty, just educate me. We've had some in the foundation group, some challenges with some contractors in another place. Did you talk to other head of estates in the foundation group just to make sure we're not accidentally choosing contractors we've had problems with elsewhere?
Yeah, I do talk to Swift on a regular basis, not so much Wye Valley. So that's something I've got in my diary to do, to talk to Christian more. Okay. And they have contacted me, that company, today, actually. So
it might be good to speak to Wye Valley a bit more, given some of the issues. Glenn?
Yeah, I did alert Kirsty to the particular problem at Wye Valley, so we'll be watching them carefully.
Yeah. Okay, have a plumber to hand. Colleagues, happy to move on? Thank you very much, Kirsty. We'll therefore move on to the report on safe nursing and midwifery staffing. Particular points you'd like to pull out, Darjit?
Yeah, thank you, Chair. I think the key thing I just wanted to bring to the board's attention, which is evident in the report, is that our nursing midwifery staffing levels have continued to be challenging. However, I think the assurance we've got in place is evident in the report too, the tight governance and the daily reviews to mitigate the risk and manage patient safety, which is evident in that we had 22 DATEX incidents and all shifts were assessed as having a severity of no harm. We've also been using the safe care tool as well to assess these shifts, and all of them were classed as safe shifts, and therefore we had no red flags raised. I think it's important for the board to note that content and just really, how positive that reflects on our senior nursing and ward teams, who I would like to praise for their hard work and their vigilance in keeping staffing safe. The report notes a rise in our safe care notificate professional judgments, but this is around the e-roster system. We've been educating our staff to use the safe care element on that so that we can further monitor the safe staffing. So we've seen a rise in compliance around that more than anything. The challenges are a mixture of annual leave, which people take during this time, mindful that a lot of colleagues have accrued annual leave, so we'll be encouraging them to take that. But also we have seen an increase in sickness, and in the background we've got the emergency elective activity, which are also growing. So all of that in combination then offers some challenges around staffing pressures. But we are seeing a similar picture nationally and locally, so I think it's important to note that. During July, the number of COVID cases increased in the community, which resulted in an increase in our staff absence due to shielding as a result of being contacted by the app and contact tracing team. And to give some context, that was a 50% staff absence due to that, which is equivalent to 100 whole-time shifts, so whole-time equivalent shifts. So it's important to take that into context. We've had challenges with NHSP been able to fill all those shifts for the same reasons. So we have increasingly relying on agency staff, but we have also had to look at off-framework agency staff in order to fill some of those gaps and ensure safety. Would like to provide assurance to the board. This isn't something that we do regularly, and we do have a governance and escalation process in place where the director lead needs to sign that off and to review the risk assessment that's been submitted. So as a result, we've just updated our internal policy to ensure that this reflects that process and that staff know what they need to do. So despite the fact that, you know, to note we have had a decrease in our vacancies for our registered nurse and registered midwives, it's important to note we've still got vacancies of near enough 60 whole-time equivalent posts, of which 43.58 of those are band 5. So we're continuing to recruit. The report highlights our sort of main areas, which are Victoria, AMU, Arbury, Melly and CAU. And we've got further 5 registered nurse recruitment days planned and 2 for healthcare support workers, and we'll really be focusing on getting staff for these areas. I'd then like to just point to midwifery. There has been quite a bit of sickness in midwifery. We're due to take a deep dive to our September Quality Assurance Committee around that, but the early indications are that some of these numbers are related to staff being off work with stress and anxiety, as well as with COVID. So we will bring some further detail to Quality Assurance Committee and bring some assurance to board via that. So this has obviously impacted on our midwife to birth rate ratio, which has improved for July. And I think the assurance to board is just, despite some of those challenges, again, with the escalation processes we've got in place, we've continued to ensure one-to-one care during labour. That's been maintained at 100%. So all our women have had one-to-one care in labour, which is a really good standard and which we've been able to keep. I'm happy to take any questions.
It was a very comprehensive update. Thank you, Daljit. Questions, Simone?
Thank you. Thanks, Daljit. I think we can take a lot of assurance from the report and all the actions that people continue to take in what is still a challenging situation. This is a request I've made before, and I think maybe it's just taking time for it to filter through. But when we see the data, could we have midwives and registered nurses figures separately, please?
Yeah.
So that we can see it for each cohort.
Yeah, I apologise for my oversight on that. I will look at that.
Let's make sure we minute that. Thank you. Just keeping the pace going, Glynis.
Thank you, and I'd agree with Simone. I think this is a really good report, and we can take a high degree of assurance regarding the systems and processes you've got in to make care stay safe. I guess my question, Daljit, is how is it impacting on the experience that patients have of care, and is it, and are we monitoring that in any way? And secondly, what impact is it having on our staff? Because I know that regularly they're having to move to cover areas as we're flexing capacity, and I know they're already tired. I just wondered if you got any feedback on those sorts of things.
Yeah, so our oversight in terms of the patient experience is through our PALS feedback and through complaints, and I think you'll see the report later on for patient experience report. I mean, the main themes around that have been around the lack of visiting more than anything. So we've not had anything around that. Obviously, we also monitor the care quality metrics on the wards, and for next month's report I've asked that we include the metrics for those wards, particularly where we're particularly challenged and we've got those vacancies. But to provide assurance to the board, the Deputy Director of Nursing has a monthly review with the ward managers and the matrons on their key metrics. So we haven't seen anything around, you know, falls or pressure ulcers as a result of this, which is really positive. And I think, again, demonstrating that we are trying to keep those staffing levels safe. And the second point, sorry, Glynis, was about
the impact on the frequent moves with staff. I mean,
yeah.
I think it's very accommodating cover where we flex beds. I just wondered what.
Absolutely. I think I mentioned in the last board meeting that that's clearly quite frustrating for staff, because one of the things that staff find as really positives, particularly during the COVID period, was working within their own teams, because that's where they get that support of. So really mindful of that. And so, you know, there is a constant explanations and reassurance given to staff. What we're looking at is that over the coming months, that should get better, because we have got more staff starting, but also there'll be a reduction in the annual leave because we're over that school holiday period as well. So yes, it does impact staff, but you know, we are supporting them and you know, providing reassurance to them in the best way that we can. But you know, very, very thankful to all of them that they've continued to make those moves and support their colleagues.
Absolutely, thank you, Daljit. I'm conscious of the time now. Just quickly, therefore, Rebecca.
Thank you. From a health and wellbeing perspective, Daljit, how is the risk of staff burnout taken into consideration when we're roster planning?
Oh yeah, so what we particularly do in the areas, particularly where we're moving staff around, is that the ward managers are actually keeping a log of the number of staff that are having to move around, and so that, you know, there's an equal there's a bit of an equal turn in people helping out in each of the areas, so to try and reduce the impact of the burnout as a result of that. I think that particularly for midwifery, where I am concerned about the, you know, the sickness figures rising and links to stress and anxiety, we do that deep dive, we'll have a better understanding of what's causing that, and they'll be able to put the right actions in place.
Thank you.
Thank you, Rebecca. And finally, Anil, did you want to make a point?
Yeah, it was just going to be a quick question to Daljit. Firstly, thank you for comprehensive report, Daljit. But you mentioned about the recruitment events, and I know a lot of hard work's been going on. Do you want to share the progress on the actual recruiting? Where are we with recruiting of the staff?
So our actual vacancies that we haven't recruited to are 59.85. So they're the vacancies. So to give a context of what we've done, a few months ago it was near enough 100. You know, in fact, it was over 100. So that's the progress we're making really on that. And a lot of those nurses, as I've said in previous reports, are newly qualified nurses. They'll be starting over September and October, which again will start to have a positive benefit for us. So I think we've done really well if we compare to other organisations as well. We've done very well with midwifery. We've got very low vacancies, and I believe that we've actually recruited to all those posts now.
Great, thank you. Well, I think the more staff we can recruit, clearly the less pressure there is, but just to reinforce the board's thanks to all of the frontline teams for the exceptional efforts they continue to make. Keeping things going then, we're on to the CQC progress and preparedness update. Daljit, just pull out the key things.
Yeah, so very brief really. I think positive progress made this month. All our must-do actions are now green. We've got 2 outstanding amber actions which are should-dos, and they are around mental capacity assessment and assessments being done, and we've got an audit due in fact today to assess where we are with that. We've also got an outstanding action around deteriorating patients. I do want to emphasise that we have made quite a bit of progress around that. We've taken that assurance to Quality Assurance Committee. We recognise there's still more that we need to do, so this is going to be part of the patient safety strategy work. So really confident that we're doing some good work around that. We've done another peer review in an imaging department, which will bring back key themes to the next meeting. The key thing I really want to just emphasise to board is that we continue to try and obviously encourage our CQC colleagues to visit us and inspect us, particularly in terms of ED, to demonstrate the significant improvements we've made since the section notice. However, some of these discussions have been impacted by the fact that we're now experiencing another change in our lead inspectors, which is the 3rd time actually in a year. I'm due to meet with the inspectors next week and have a handover meeting with them.
Okay, thanks, Daljit. Glenn, I think you and I have got the same view on this report. Your view on its need to come to the board every month?
Yeah, obviously we're tracking a number of recommendations at a point in time of an inspection a little while ago now, and we've made such good progress. I think we should business as usual this now, push it over to the quality committee and not bring it to board. Yeah.
If anyone is not happy to do that, please raise a digital hand. Okay, so we'll do that. Any questions on this report though to Daljit? Okie dokie. So Daljit, as ever, you earn your salary at the board. We then have the annual report on patient experience and complaints. Obviously take it as read, but anything you'd particularly like to emphasise?
Yeah, I think we've got a lot to celebrate with this report. I think it really demonstrates the great work that the patient experience team under Becky Millwood's leadership has done, and would like that noted and acknowledged. Also the improvement in the complaint response rate. So I'd like to acknowledge the work of Sharon Wyman and her team in enabling us to do that. I think we've got a bit of work to do around how we, learn better from our complaints and to make it a much more streamlined process, which we'll be doing some improvement work around. The other area of celebration I think we can take assurance from is a friends and family test, where 90% of our patients would recommend George Eliot to their friends and family. And we're forever, really grateful to our patients that feed back to us and give us that information. During COVID, clearly a very challenging time for loved ones to visit their families in hospital. So our new letters to loved ones was a great initiative we should celebrate, and delivering parcels to homes, but also the volunteer driver service, which has had very, very good feedback as well. During this time, we've also implemented the new interpreting and translation service as well, which we're just about to, we're just embedding really. I'd like to take this opportunity also to thank our patient forum. Whilst we've been unable to meet with them face to face, they've continued to be key in working with us to both highlight any issues that we need to look at, but also to support us in making those improvements. So I think this is a really positive report and a lot of people to be congratulated.
No, thank you, Dalgin. Absolutely, regarding the thanks to colleagues. And just to assure members of the public, even this morning, we heard of a bad patient experience with the breast cancer service from a patient who came to George Eliot, albeit it was UHCW service. So we are continuously trying to improve and listen to our patients. Any questions from colleagues on this report? Julie?
It was just to reiterate something that we said earlier, Russell, which was around the key issue that came out of that patient story this morning was around communication. This is echoed in here, and we agreed, didn't we, to really look at the area of communication across the piece.
Yeah, no, absolutely. The NHS is not great at ensuring it keeps in touch with patients as they go through a particular pathway, as it's called. Any other questions from colleagues? So normally we look forward and invite David Elchingham to give us an update on the Integrated Performance Report. Today we have the pleasures of Ms. Catherine Free. So Catherine, over to you.
Thank you, Russell. Well, I'll try and do David proud. So I want to start off with the quality report, because there's some really positive areas to celebrate. And the first one that I want to draw attention to is one that's close to my heart, which is our mortality indicators. Because the first time in many years, both of our mortality indicators, our SHIMI and our HSMR, are within the normal range. So that's 100 for SHIMI and 103.4 for HSMR. So that's a really great position to be in as an organisation through a difficult pandemic. Actually, our mortality figures have improved, which is, I think, on the back of the other quality indicators, good patient care being demonstrated there. So in the other quality indicators, I won't go into it in detail, but the infection prevention and control indicators are really positive. High trust cleaning score, no MRSA bacteremia. Falls and pressure ulcers, also areas to celebrate. Our falls performance is 4 per 1,000 bed days, which is below the national expected figure. And pressure ulcers, we had no avoidable pressure ulcers during the month of July. Daljit's already commented on our complaints performance, but that has improved with 100% of complaints responded to within the 25-day target. That has been an area historically that's been really difficult for us to meet, but again, really pleasing to see that improve so significantly. And Daljit's just mentioned it, but it's worth another mention. The friends and family scores are really pleasing, and I just draw your attention to maternity because of the national scrutiny on maternity and people not looking at that. Our maternity patients are telling us that 92% recommend the trust as very good or good experience. And the other thing to draw out of those friends and family tests is the response rate. So we've got really high response rates as an organisation. So I think we can be confident that this is a true picture, and well done to our staff and our patients for encouraging each other to give us that feedback that we can then use. Also, David doesn't normally give this a shout out, but I'm going to give it a shout out now. Our VTE performance for assessing patients at risk of thromboembolism when they come into hospital is now at 97.1%. We had such difficulty meeting that standard, and we are now consistently hitting that standard. So I felt that was worthy of a quick mention. In terms of some of our operational performance, as a board this morning, we've spent some time considering the operational pressures. This summer is, as Amanda Pritchard has said, is one of the busiest summers, if not the busiest summer on record. And we are experiencing that locally. In July, our ED performance slipped to 88% in July. However, in terms of our peers, that still puts us very high in terms of the Midlands and nationally. So I think we still would like to do better, but the high levels of activity and problems with outflow and moving patients through the hospital have contributed to that. And there was one ambulance delay of over 60 minutes in July. Positive news again on our RTT performance, still a long way from where we want it to be, but in the context of the backlog that's built up over the pandemic, the backlog is reducing and the RTT position continues to improve to 69.7% for July. And the other thing I think I want to draw the board's attention to is the significant reduction in the number of patients waiting over a year for treatment. Those numbers grew significantly during the pandemic, and we're working very hard to reduce those numbers, and a huge thanks to the team who are treating those patients who've been waiting so long for care. I think we must highlight that we missed the diagnostic standard this month, which is the second consecutive month. We were first in the country in terms of our diagnostic performance. That's probably related to some issues with cystoscopy that we're working on addressing, but that has been an area of good performance historically. One of the areas we have struggled with and continue to struggle with is our stroke performance. So this is the patients with stroke that spend 90% of their time on a stroke unit. That's 67% in July, and it has been bouncing around. Sometimes we hit it, sometimes we miss it. I think that's really being impacted by our infection control measures, that we have to test all our patients for COVID. We can't mix patients about. So that is having an impact, and the impact of the increased level of activity and the difficulty of discharging people back to their own homes when they need extra support. Cancer pathway performance, 2-week wait and 31-day performance meets the standard. 62-day performance is below the threshold at 82.5% against a target of 85%. And historically low levels of people waiting a long time for treatment, just 4 patients waiting 104 days for their cancer treatments, and an area that we're continuing to focus on. So in terms of people, well, I won't go over the vacancies. Daljit's really highlighted the challenges around Band 5 nurse recruitment. But there is one thing I want to pick out in the people section, which is the high levels of statutory and mandatory training. Again, this is a real testament to our staff. We're trying to move our staff towards seeing this important training as crucial for safety. And the levels are extremely high given the pandemic and the challenges our staff have been through. Appraisals, we've got a bit more work to do in that area, currently at 78.7%, but the rate is improving against a target of 85%. And that's an important area of focus for us as an executive team, because it's really about making sure we support our colleagues and make sure that we're developing them and spending time to talk about what matters to them. So that really is a canter through the IPR. Happy to take any questions.
Very comprehensive canter. Thank you very much, Catherine. I think you're so much better at it than David. Glenn?
Better at it, and better numbers as well in many cases, so long may she reign. Just picking up one point there Catherine. One of the really positive things actually is the position on HSMR, but on page 83 out of 271 of the pack, we've got the HSMR weekend at 94.3 as a red, and it should be green. No, we need to get green.
Yes, it should be green. And obviously I was going to make some quip about the fact it would have been greener if we'd marked it all correctly, but I didn't want to draw attention to that. But actually it's a really important point, Glenn, because weekend mortality, I mean, nationally, the risk of dying if you're admitted to hospital on a weekend is higher across the whole country. So to see that performance at 94 is actually really very positive. And our weekend mortality rate has been lower than the expected figure for some time.
No, great. Thank you, Glenn. Thank you, Catherine. I think the A&E performance in the circumstances has been phenomenal, as you suggest. Glynis?
Thank you, Chair. Catherine, you may not know the answer to this, but I'll just put it out there anyway. We talked about our cancer pathways and particularly weights when we've got tertiary providers across a pathway. I just wondered if you've got any sense where we were on the 38-day inter-transfer. So are we transferring patients in a timely manner on cancer pathways?
So I don't know the exact answer to that, Glynis. I don't know if Phil is aware of and it can help us with the cancer transfers.
Phil, any joy, or shall we minute it as an action?
I haven't seen the latest figures. I've been up for a few weeks, so I can get back to you on that, to be fair, to give you a more accurate position.
Okay, thank you, Phil. Thank you, Glynis. And any other questions or perspectives? The only sort of final point I would make is to members of the public. We did spend a lot of time this morning having a discussion about the forward look as we enter the autumn and winter. And I think, I certainly do expect things to get tougher before they get easier. I think the combination of the challenges in the care home sector, as well as the normal winter pressures, and our staff are often feeling very tired after the burdens of the last 18 months, means it's going to be a very demanding few months. So hopefully David will be able to report the type of performance you've been able to, Catherine. Okay, team, we'll move on then. And as I said, Hack isn't with us for the finance report, but Michael, we still live in strange times in terms of the financial numbers. Anything you particularly like to put out?
Thank you, Chair. Yeah, I mean, this month has seen us flip our prior year-to-date surplus at month 3 into a year-to-date surplus now. Year-to-date deficit now. This has been primarily driven by the change in the ERF threshold that was made on us from 85% to 95%. That's therefore impinged the amount of income we can earn, and it's meant that as a system as a whole is reporting a deficit, and we are taking our share of that deficit now. It's in the report at 1.6 million. It should have been 1.3 million, but I had to do that because that's the system to align to it. It will be restated at 1.3 million deficit by the end of September when we do the month 5 report. So at the moment we are reporting year to date 0.6 million deficit in line with that, and I'm expecting just under 400,000 deficit in August and September to finish the year out. Key messages are, due to the ERF performance and activity being lower than target, and that's due to the pressures we all know about, capacity, COVID sickness, beds, etc. We're still confident we can mitigate our shortfalls. Primarily, we're spending less on activity because of that. We're spending less on COVID than we're forecast to spend, and we've got a significant number of vacancies. Reiterating, the deficit is purely due to the threshold change, and obviously this is an income issue. Our costs remain under control, and we believe, good grip on them. Looking forward to the second half of the year, we've still got no planning guidance or clarity on our income levels, but we again remain on the front foot, particularly regards our CPIP programme, which we're making progress on, and along with our approach on empowering directorates, we enjoy good buy-in, and we've obviously got oversight of the FPE. I'm quite happy to take any questions on the actual numbers or anything else anyone wants to know.
No, that's great. Thank you, Michael. Very clear. Glynis, I assume that's a digital hand. Questions or perspectives? Anil?
Thanks, Chair. Michael, quick question. Earlier on in Kirsty's report, we saw some slippage in the capital project. So are there any major impacts on our capital plan for the year?
I've been through it with Kirsty and Sunita. We still, at this moment, we still believe we can catch it up and actually expend our 6.6 million this year, as well as the CDH monies that are coming in. Obviously, the caveat on that is, are we going to be buffeted by any issues around supply and demand, as you know, goods seems becoming scarcer. Therefore, we're seeing some real restrictions on how quickly we can get building materials, etc. But at the moment, I think hopefully Kirsty will confirm that with me, that we remain confident that we can meet the capital programme this year.
Okay, thanks, Michael. And any other questions to Michael? I think just on that last point, I think it's almost inevitable we're going to see a significant increase over the next couple of years in inflation, in particular building cost inflation. So it would be wise to just be prepared for that. So I think we therefore can move on to the Freedom to Speak Up Guardians report. Come in, Sue. Sue, are you there?
I am, thank you, Chair. So I'll take the report as read, and there's a couple of areas of update actually, because I've just come from a meeting about one of the actions here. So the action around radiology team, you'll know from previous reports that we've had a lot of activity around radiology. We've had some whistleblowing over the last couple of years, and also some Freedom to Speak Up cases through myself. So we've got a really robust action plan in place now to start addressing some of these actions and try and tackle some of the issues that have been raised. Some are historic, some are new things that have been brought to our attention over the last couple of months. But we've started some of the work already, so we're rolling out things like civility training. We're mandating through appraisal of the teams that they should attend things like the Speak Up training, the Listen Up training, that they should be involved with civility, and that all leaders above Band 7 are to do the leadership course, even if they've been in post for a long time. A refresher absolutely would be good, and that includes the medical staffing and other staff. So that's really good. And we're hoping to increase our complement of Freedom to Speak Up and wellbeing ambassadors within the team, so that we've got a strong team there that can then maybe look at a staff forum initiative where they can raise concerns through a safe space on a regular basis, rather than waiting until things escalate and they need to do a formal Freedom to Speak Up. So some really good work with that team, and the directorate have been brilliant at supporting that as well. So that's really positive and hot off the press. You'll see from the report this time that we were down on numbers. We only had 4 cases, which is amazing in one way, but then slightly worrying in another, because we're used to having high numbers of reporting. But I think it's important to say that the contacts with the Guardian team are still high, but we just haven't classified them as a Speak Up case, because there's been things about, I don't like this poster, or we haven't advertised that, where do I find this? So there's lots of work and lots of signposting going on, but not necessarily formalised cases this quarter. The things that have been dealt with, you can see from the report, we only had 2 from a nursing background and 2 from the admin teams. They've all been signposted, and all of those have been resolved now, the majority of which has been done by their own division, which is brilliant, again, to see that work happening at a general manager and below level, rather than escalating up to you guys. So it's been really positive this month, and we've really been focused on delivering the civility training and planning for October's Speak Up month and conference. So it's been really busy, even though a low reporting quarter. So happy to take any questions.
Thank you, Sue. I mean, the bedrock of all of this is the civility work that we're doing, and the importance of behaviours and values. Thanks, Sue, for your hard work. Any questions or perspectives to Sue? Rebecca?
Thanks, Chair. Thanks, Sue. I'd like to commend you for your hard work and commitment in getting us to where we are now in George Eliot's programme with Freedom to Speak Up. One quick question is really in regards to when we might receive an updated Freedom to Speak Up policy, because it's been a little while since we've revisited the policy, particularly in light of learning from, external investigations and national inquiries, please. Thank you.
Oh, you must have been on the NGO briefing today. So the NGO and NHSEI have been looking at the Freedom to Speak Up national policy. We've heard from them today that they want our opinions on that policy back by the end of October. Deepa and myself have reviewed our internal process already, and we will be at the stage to send that out for further comments through the usual routes, probably by the end of this month. But we might wait and see what happens nationally as well, if it's only going to be from October, just in case we're completely off the ball with what National say we should do. But I don't think we will be.
Okay, thanks, Sue. Thanks, Deepa, for joining us as well. And any other questions or perspectives? Looking forward to October, team. Anything you want us to do, just ask.
Thank you.
And great to see the learning that's going on, the mutual support across the foundation group. We were talking about the disabilities working group earlier, and that Matt is supporting from Swift. So that's great stuff. Okay, take care. Thank you.
Thank you.
There's no summary of ratified policies because the meeting was stood down. So I think we're then into the annual safeguarding report. Daljit?
Yeah, thank you very much, Chair. Just very briefly, the report provides assurance to the board that we have maintained our legislative requirements in relation to safeguarding. The key area and challenge that we had last year was around the lack of a children's safeguarding doctor, which I'm pleased to report we have now appointed, and the paediatrician is undergoing their training. The key thing the report points out, and this is also reflected nationally, is a significant increase in the complexity and numbers of referrals we're having in terms of safeguarding as a result of the pandemic, both for the children's and the adults portfolio. This has had a real impact on the safeguarding team, and with the introduction of the new liberty protection safeguards in 2022, this is likely to add additional pressures. So to ensure that we can meet this, we did place this on our risk register. We developed a business case, which has subsequently been approved by the Trust Management Board. So we'll be able to appoint to some additional posts to ensure that we continue to maintain our national and legislative requirements. I would like, if I may, Chair, to take the opportunity to thank our very small safeguarding team, which consists of Natalie Asher, who's the children's safeguarding lead, and Sally Wilson, who's the adult safeguarding lead, and Stephanie Rowlands, who's on maternity safeguarding lead. I think that they have done tremendously well in supporting our staff around safeguarding over what has been probably the most pressure that the organisation has had. So my thanks to them for their amazing work.
Absolutely, Daljit, and amazing work and incredibly important work for the individuals that they are seeking to support and protect. Any questions or perspectives on the annual safeguarding report, Julie?
Just a quick one, Daljit. I think the increase is consistent across all organisations as well, and it's showing how organisations are having to work together around the complexities now. Just in terms of Natalie, I thought the report was really good as well. The one thing I missed was it sets out the support to adult safeguarding lead, but I didn't see the support to Natalie. I don't know whether that's because I missed it in the report or whether it was missing. I
think it's probably missing. She does get the support as well. They both get clinical supervision, and the business case will be additional roles in both adult and children's.
Great, thank you, Julie. And any other questions or perspectives? Okay, so please pass on our thanks to the safeguarders. We therefore move on to another incredibly important area where some great work's been done, which is infection prevention and control. Back with you, Daljit.
Yeah, thank you very much, Chair. Again, yes, I think a team that has met many challenges. It's been quite a year for them, and certainly tested their skills, resilience and their grit, and I think they've risen to that challenge, and this report really demonstrates that. I think there's a lot to celebrate in this report. Catherine mentioned some of the how positive the infection control indicators are in her report. But in addition to managing the high numbers of COVID, the team have really demonstrated how quickly they've learnt about COVID, and they've put those lessons, you know, into practice to ensure that we keep our patients safe and to minimise outbreaks. Again, this was a very small team when we started off, and we're really pleased that we've been able to add some additional resource into that team. The board, I just want the board to note that it's a very tough market recruiting for qualified infection control nurses. So we've taken a sort of a medium to long-term approach in that we have actually appointed nurses, and we're training them. So while it will take some time for them to be fully fledged in, you know, specialist nurses, they are doing a great job, and they're adding a lot of value to the team. And I think in terms of retention opportunities for us in the organisation, we've had really positive feedback from our staff that, you know, it's been a while since they've been able to, you know, apply for a specialist post. So for retention, it's really great. In terms of our indicators, I think, you know, as said previously, you know, we've had 0 MRSA bacteremias last year. We also saw a reduction in our gram-negative bacteremias, and we had no reported cases of norovirus as well, and some organisations had. So that's fantastic. We had 18 C. diff cases, which is slightly over our target, but what's very positive is that the CCG have reviewed these with us, and they've all agreed with, along with us, that they were all deemed as having no lapses in care. So that's really positive as well for us. Again, I'd like to just, you know, commend our infection control team, led by Emma Halfacree, who during this challenging period took up the role of matron, and she's done a splendid job and provided great leadership for the team. So my thanks to the team really for always being professional and supporting high standards of infection prevention and control.
And it's true of so many of these teams that sort of work almost below the radar, but are absolutely the bedrock of ensuring that the strong performance that Catherine was talking about earlier is based on, you know, solid building blocks. Questions or perspectives, Glynis?
Thank you, Chair. It's just to add to what Daljit said. I mean, with some of these reports have gone through QAC and have received significant scrutiny, but for the infection control prevention one, we actually had an external consultant who's been supporting us come in to present the report. And I just want board to be aware that she was absolutely blown away with the work that the team have done, and hugely impressed. And so it's not just internally, it's external people that are recognising the work that they've done. Yeah,
no, great. And Phil talks about it being a robust team, and Rebecca talks about the exemplary work. So really great. Please pass on our deep thanks. Any other questions from colleagues? So I think we're then on to the combined health and safety, fire safety and waste management annual report. Kirsty, back with you.
Thank you, Chair. Just to say that the report outlines that the Trust is discharging its obligations for health and safety legislation. And just draw your attention to some of the highlights, I guess, within it, because I'm assuming that everyone's read the report. The first one is that we received 2 health and safety executive interventions. The first one was an estates-related issue following some testing of our generator. Which unfortunately some of those fumes went into one of our theatres. We installed basically a massive catalytic converter onto it, and the health and safety executive were content after that we'd actually resolved the problem, and they closed the case, which is good. The second one was about an occupational death of a member of staff, which was reported. But following investigation, they were satisfied that the risk assessments and that the processes put in place, that it wasn't a work-related death, and as such, the RIDDOR was notification was withdrawn. The report highlights some of the issues about compliance, particularly estates compliance on asbestos, portable appliance testing and lifted equipment. Just to say that plans are in place with those, and we are ticking the box in terms of compliance. There are a number of estates related projects that were completed last year, the Captain Tom Moore building being one of them, and the installation of the Vanguard Theatre. We were lucky to receive £200,000 for LED lighting last year. And then there were a number of compliance schemes, and the HSDU refurbishment, which we couldn't actually do because of coronavirus, but we did get on and solve some problems with our plants. which has resolved some issues in HSDU. Catering department, we've replaced all the flooring throughout there, and we are now achieving a 5-star food hygiene rating. And the best one is the maternity infrastructure works, which isn't about making it look pretty, but it's trying to solve the problem behind the walls. So that one's really welcome. We've got another couple of years at that one, but hopefully once that's done, that building will be fully compliant. So that one's very exciting. The incidents that were reported through Datix, there were 593 health and safety incidents reported, which is actually a decrease on the previous year. This is probably down to the reduced activity within the hospital. The top 3 incidents were verbal and physical abuse at 238 incidents, exposure to unsafe environmental conditions at 156, and slips, trips and falls at 46. The highest one with the verbal and physical abuse was actually verbal abuse staff to staff at 95 incidents. And I think alluded to it earlier in the Freedom to Speak Up about the Civility Saves Lives sessions that have been helped to try and help staff to understand when they're talking to people, you know, the impact that it has on them. The exposure to unsafe environmental conditions as well as fire, the main was about high temperature, because last year it was really warm, unlike this year. The riddle reporting was slightly different, slightly higher this year due to coronavirus. So there are 43 incidents reported in comparison to 18 last year, but 32 of those were relating to COVID-19 outbreaks during the second wave. So that skewed it slightly. In terms of fire, there were 81 fire calls last year. Only one of them was an actual fire, which was outside of the maternity building. Somebody discharged a cigarette basically and set fire to some leaves. So the fire brigade were called. No one was harmed during that incident. And there were 80 false calls. 21 of those were related to cooking, which is predominantly burnt toast. And the other 25 were false alarms. So somebody hitting the alarm because they thought they could smell something. All are investigated in Datix. Fire training, we're at 91%, which is above the trust standard of 85%. We do need to look at fire training because obviously last year due to coronavirus, everything was done online. And it's a requirement of the Regulatory Reform Act that every other year it's done face-to-face. So we're working with L&D about how we can reinstate those. In terms of waste, waste actually dropped last year in comparison. Although the volume of waste went up, the actual tonnage went down because PPE doesn't weigh that much, but we did get through an awful lot. In terms of energy, carbon footprint actually was at 6,049 tonnes of CO2 emissions from our buildings. Our electricity consumption did increase by 40%, but that's predominantly because we had a larger footprint. Gas consumption increased by 3%. But it's interesting to note that since we've gone live with the CHP, that's the combined heat and power energy, we've actually reduced our overall emissions by 700 tonnes. And obviously we continue to see what we can do with the CHP to reduce that further. There were 6 incidents as well relating to waste management, which were all low harm. And that about it picks up the salient points there. So if anybody has any questions.
That's great. I think one of the key bits of training coming out of that report, Kirsty, was how to make toast. Questions or perspectives, Glenn?
It's a great report, Kirsty. Lots of good work going on. So thanks to you and the team. Just on the ventilation upgrade, obviously we've learned a lot through COVID and we've been trying to understand what the future needs are. Have we completed our thinking about what we need to do next on that?
Yeah, we've attended a number of webinars, got a load of guidance that's come out that we're going through. Obviously, the majority of our areas are naturally ventilated, but we have identified some areas that the ventilation needed upgrading. So cardiorespiratory, that's just been completed, and some other areas. So key areas, particularly where we're doing AGP functions, we've looked at and centred on. But yeah, we have reviewed it.
Okay, thanks, Glenn. Thanks, Kirsty. Just keeping things moving. Phil?
I'm just going to ask one thing, Kirsty. I mean, it's a good report. It's really clear. I just noticed that electricity consumption's gone up by 40%. Is that because of the new ward and the theatre?
Some of it, extra areas that were open. Yeah,
Right.
so some of
Seems
it.
a
Yeah.
lot, doesn't it? For us,
Yeah.
just
We had
Friday very lot of
you just think about ITU, the amount of equipment that was used when it spread into theatre recover 24/7. It's just the marginal gains that it went up. So
Okay, well, I'll talk to you outside anyway, because just
yeah.
intriguing. Yeah.
And that was despite us installing the LED lighting, which should reduce the electricity consumption.
That sounds like a big number. And finally, Rebecca.
Thanks, Chair. Kirsty, what ways are we ensuring that we engage our staff in sustainability and, you know, the kind of environmental impacts that our equipment is having? What methods have we got in place at the moment?
So there isn't an awful lot at the moment, I'll be honest, Rebecca, but obviously with all the net zero carbon coming out and the guidance, there's a real impetus now, and obviously our sustainability development plan is being put in place. So there's a real drive to engage with staff more and to make it so that we can make a difference, really. So it's a work in progress.
Okay, great. Thank you, Kirsty. And finally, Glenn.
Yeah, so just on that, the sustainability strategy is coming together. We've got good sharing across the group. Wye Valley are installing heat pumps at the moment, which is a really interesting project that we'll be looking at to see whether there are benefits that we could look at across the group. So I think it's a really important thing actually to use our anchor institution muscle to do something about sustainability. So you will see a lot more on this.
No, great. Okie dokie. Thank you, Kirsty. Colleagues, happy to move on. So we then move on to the Equality, Diversity and Inclusion Annual Report. Sarah, over to you.
Okay, thank you, Chair. So this report gives assurance of how we're performing against the 9 RES indicators and the 10 WDES indicators. The report does contain a lot of information, so you'll be relieved to hear I'm not going to go through it in great detail. But I think that just reflects the volume of work that's being undertaken to ensure that we are a diverse and inclusive organisation and that all our colleagues have a fair and equitable experience at work. Our staff networks play a crucial role, and they are actively engaged in developing and delivering the action plans that are outlined in appendices 2 and 3 of the report. Overall, we have seen an improvement in both our RES and WDES indicators. We do have some specific areas of improvement, though, that we are focusing on. The people development team have done an awful lot of work to reach out to the harder to access groups. And we do hope that through the Kickstart, Step Up and apprenticeship programmes that we can engage with people who might not usually have considered a career in healthcare. So again, thinking about our role as an anchor institution, how we get out to those areas of the community. Happy to take any questions.
That's great, Sarah. And it's just really important to re-emphasise on behalf of the whole board our total focus on providing the best possible opportunities for all the citizens that we serve. We're interested in the content of your character and your competence in doing the role. That's all we're interested in. Any other issue is totally unimportant. We want to encourage the broadest possible mix of different attitudes, mindsets, backgrounds, whatever they are, to provide us with the rich tapestry of the citizens that we serve to enable us to do our job better. Any questions or perspectives to Sarah? Okay, thank you, Sarah. And so we'll move then, I think, on to the subcommittee reports. The first are those from the Quality Assurance Committee of the 26th of July, where we have the report, and the 23rd of August. Glynis, what would you like to highlight?
From our last meeting, it was a very packed meeting. We're catching up on papers delayed because of COVID, and as you'll see, a number of annual reports. But overall, I'm really pleased to report it was a really positive meeting. We took good assurance across a wide number of areas, such as mortality, patient experience, nurse quality, CQC, BAF, so really positive meeting. But just a couple of areas to flag where we're seeking further assurance. The first one is workforce. As you know, that's nationally and locally a real challenge. So one of the things that we discussed and have agreed is to review the format of reporting so that we align that similar to nurse quality, where we get monthly overall reports, but we actually do deep dives into particular areas, which strengthens our assurance, particularly where there's areas of challenge. And some of my fellow NEDs from Quality Committee will be working with Gertie on that for us. The other area we've sought some further work is on the health and wellbeing self-assessment framework. This is a really important diagnostic tool that will help us to ensure we're providing all the appropriate and best possible support to our staff, and we're conscious in these times with burnout that that's important, so that will be coming back to QAC. As Daljit's mentioned, we've asked for a deep dive into sickness in maternity. Again, that's just really having a better understanding of that, and that'll be coming back to our next meeting. The other thing just to flag is we also had a discussion regarding CQC strategy going forward for regulation, particularly in light of integrated care systems. And I have to report there were really very strong feelings expressed by almost all members of the Quality Committee relating to the Section 29 notice that's still in place with our trust. We believe that it's no longer appropriate. We have evidence to that, but it is of concern to us because it does impact on us reputationally. We feel it misrepresents the service as it currently is. But particularly as we're moving into an ICS where we're assuming a role as a lead provider. So I'm aware that this is something that's been raised before, but we just wanted to flag it to board saying, you know, we probably do need to raise this once again with CQC because I think it is a potential risk, particularly when we're looking around workforce recruitment. And finally, I just wanted to say we also received an annual report on volunteering in the trust. And I just urge everybody, because it hasn't come to board, if you have the opportunity to read this report, because it was hugely uplifting and inspiring. It was so good to see the amazing work that's going on with volunteers, some great practice going on. So if you haven't read it, I really think it's worth taking the time. It's an easy report, but we really would want as many people as possible, not just our board, but the general public to read the great work that's going on at George Eliot. Happy to take any questions.
Fantastic summary. Thank you, Glynis. Any questions or perspectives, Glynis? Super. Thank you, everyone, for your hard work in that subcommittee, and particularly your team, Daljit, because I know you do the majority of the stuff behind the scenes. So I think we're on to any other business. Any other business from members of the board, please raise a digital hand. So any questions from members of the public? So I don't think we've had any notified questions, have we?
We've just had the one from Tilly Mills, which is ophthalmic services are being provided by the trust after being bought back in-house from another service provider. Can you give an update on ophthalmology, on how ophthalmology is performing, any changes in the service that have been introduced, in impact on outpatient appointments and waiting lists for surgery? With the age profile of the community, the hospital serves, and hence the increase in associated eye conditions such as cataract, what are the future plans for ophthalmology services? I think Philip's going to answer this one. Thank you.
Yeah, I can answer that. The question is right. We have set up a new service now. Our original provider withdrew a couple of years ago, I think about a year ago, and we have tupied over some of the staff from that, and we're working with consultants on a contract basis to improve the service. Immediately, just to catch up with some of the performance that we showed this morning, in April, our 52-week waiters in ophthalmology was 148. And a couple of weeks ago, the last one I got, it was down to 39, which is a 75% reduction in long waiters. At the moment, for example, I mean, we're doing a lot of work with the teams that we've taken on and with the local consultants. We're working throughout the weekends as well. Our outpatient waits, for example, for cataract surgery, which for that particular case mix is an issue, is now on average of 13 weeks at maximum. We can get a 13-week appointment, and at that appointment date, you'll be given a surgical date if you need it in the next 8 weeks. So moving forward, the view is we want to establish early next year an integrated community and hospital eye service with our CCG stakeholders in the new place context, which will look at working with community optometrists to have fast tracking of patients into GEH. Obviously, emergency surgery requires GA or traumatic work. We're still done at UHCW, but early next year we're hoping to re-establish an integrated system at GEH.
Great, thank you, Phil. Glenn, anything you want to add to this?
Yeah, just agree with everything Phil said, and strategically, ophthalmology services, the bread and butter services should be delivered locally, should be delivered in George Eliot. So getting that back within the hospital and taking that forward is really important in the way that Phil's described. One of the other things we've been doing though is this is part of the group-wide productivity and clinical efficiency programme. So we had the first meeting. Ophthalmology is the pilot specialty for that on Friday of last week, looking at best practice across the group and seeing how we can increase the productivity of waiting lists to see more patients as quickly as possible. And that meeting went really well, actually. So looking forward to seeing some of the results of that.
Great, thanks, Glenn. Just before I move off this, Natalie, I see your hand's gone up. Did you want to come back on this?
Yes, just really to say thank you for the update. I think in the patient forum, it's one of the conditions that we do get asked quite a lot about is ophthalmology and cataracts. So that's really helpful to know that, and we can feed that back. I'd just also like to say, again, listening to the board and all the good work that is going on, it is really reassuring and heartwarming for patients. And I would just like to do a special mention around the mortality figures, which are absolutely fantastic, and all the hard work Catherine Freer has done around that.
Okay, thank you, Natalie. So going back to other questions, Keith Condacol.
Thank you very much, and welcome back from your holidays, everyone, or hard summer of work, whichever. One thing I was hoping to get out of the report at the beginning was where we are with the COVID numbers, because obviously they've been going quite flat nationally, maybe creeping up a bit, but obviously we could be getting more pressures as winter comes. So I'd like to have a bit of an idea on COVID numbers, and also the pressures because of the overloading of 101 and GP surgeries. I did try 101 myself over the bank holiday and never got anywhere. So I didn't know if we're doing anything or getting anywhere with what's happening with those overloads on 101, and if that's causing more pressures, people actually attending the hospital, because it's quicker to get to the hospital rather than actually wait on the phone. Thank you.
Thank you, Keith. So those two questions, COVID and, if you like, primary care. Glenn?
Yeah, happy to take those. Hi, Keith. The position on COVID is obviously a lot better than it was when we had the peak in January. Even though we are still seeing high numbers of cases in the community, in fact, in many cases higher than in January, that's not translating into the same level of hospitalisation, but that doesn't mean there isn't hospitalisation. So our latest figure is 14 cases, COVID positive cases in the hospital, not all admitted because of COVID, so some admitted with COVID. That's probably a number we just need to get used to, actually, because that is a kind of level that we are seeing. And if you look across the foundation group, similar numbers in all of the trusts. So we're kind of into endemic COVID rather than pandemic COVID now. But you know, the fact that we haven't got this translation of COVID cases into admissions is demonstrating how well the vaccine is working for us. But as we've already said, the demand in all other parts of the NHS is still incredibly high. A&E 111 first is an important part of responding to that, and primary care colleagues are working through recovery themselves also. But I think there's still some issues we need to work with the community around how they use urgent care, So even where primary care are available and open for business, some patients are choosing to walk in through the front door of hospitals, or indeed in some cases, having seen primary care and been treated appropriately by primary care, still seeking to come back for a second opinion almost by using acute services. And it's those kind of patients we need to ensure we don't see over the winter, because they just add to the pressure that we're under. But we work very closely with our primary care colleagues. Catherine has particularly worked closely with them over the past few months to develop a place-based strategy of integrated care, and so we're in a good place as a system. But the demand is high, and the added reality that there will be a number of COVID cases in the hospital for the foreseeable future means that we have to manage that pathway so that we have really strict infection prevention and control, so that there's so we're keeping everyone safe. So it's a tricky scenario, but it's nice to see the numbers at the lower level compared to what we had in January.
And Catherine, anything you'd like to add to this?
Yes, I mean, Glenn has touched on the vaccine, but I can't let the opportunity go without a bit of a public health message. The number of patients in ITU with COVID who are not vaccinated is disproportionate when you look at the number of patients in hospital. And we know what Glenn has already said, that the reason we haven't got higher levels of people in hospital is because of the vast majority of the public have been vaccinated. But I would encourage any member of the public that hasn't been vaccinated for COVID that's eligible, please take up your offer of a vaccine, because it is so important in terms of protecting people from very serious illness from COVID. And so if there's anything that we can do, we are still offering vaccinations as an organisation to allay people's concerns. We'd be happy to take the time to discuss that, or GPs or the vaccination hubs, because it is so important we get everybody that's eligible vaccinated.
Thank you, Catherine. And then finally, David Carr.
Thank you, Chair. Just a couple of points, if I may. The new model of working, I guess, and the increased number of staff in ED, to the weekend mortality rate reduction to 94, I think is absolutely tremendous for Catherine and her staff. The other thing, Glynis, I also endorse that people should read the volunteer report for the George Eliot. And then there's the patient forum are involved in a new program, which is very embryonic, which I think is called the Comfort Calling program, where we extend our arm to patients that have recently been discharged. And the feedback on the early stages of this program is how really, really satisfied patients are once they've been discharged from the George Eliot. But my question, Chair, is it's been well reported globally, I think, that there's a national shortage of blood test tubing. How is this impacting on the service for our patients at the George Eliot Hospital? Thank you, Chair.
Okie dokie. Glenn, do you want to start off in that? Maybe Phil come in afterwards.
Yeah, I mean, obviously this is linked to a world shortage of plastics, actually, and we've been responding as an NHS. A lot of that's actually because of PPE. We've been responding as an NHS to that issue. Catherine may want to add to this, but there's been guidance given to all trusts and to primary care colleagues. We are continuing to offer blood tests where they are needed for our patients, but it's where we've got kind of routine bloods, mainly primary care related, that we are trying to contain that. Hopefully this is something that won't have to continue for much longer once that supply chain is resolved, but it's I think we just probably need to look at other plastic items as we move forward as a nation, because this is a problem that is going to face a number of supply chain issues.
Phil, anything you want to add before I go to Catherine? You're on mute, mate.
I have no doubt Catherine will support this, that we have got a working party across the Warwickshire at the moment with all the providers looking at how we can be more expeditious in how we do blood tests, etc. And everybody's working across on that, which backs up what Glenn said. But I'm sure Catherine will put more authoritative detail than me.
I was going to say no direct impact, David, just as Glenn has said, in terms of our ability to perform the tests that we need. But we have cut back on any unnecessary blood tests, which we should be doing anyway, and things like blood tests for research that are not as clinically important. We are trying to cut down on that, things like vitamin D testing in the community. So, so no direct impact to patients, but as Glenn says, it's blood bottles, Diet Coke cans next. So a lot of things that we're going to be grappling with differences in supplies.
Well, on behalf of the patients in your area, thank you very much for that reply.
Thank you, David, and thank you all members of the public. Hope you've enjoyed this board. Look forward to seeing you in the next one, the 5th of October. To my board colleagues, we'll now have a 15-minute break and we'll start the confidential board at 3:45. Thank you. See you then. Bye-bye.